Hello.
Yes, sir.
Hello.
Yeah, sorry. Technical team is there.
Hello.
Yeah, hello, Nishant sir.
Yes.
Yeah, very good evening, sir. Very good evening, everyone. Here with us, Dr. Nishant Anwab, leading consultant physician of Ruban Hospital. Yes, sir. Please start, sir.
Oh,
Doctor, requesting you to turn on the camera.
Hello. Hello, technical team.
Hello, yes, sir.
Is there an issue to open the slide for the doctor?
No, there is no issue, sir.
There is no issue, no? So, sir has decided.
We make it correction. Since the diabetes and hypertension.
Oh.
So the slides are visible to you all.
Hyperchlorothiazide, also clearly indicating the CV event. Then coming to telmisartan, what role it has? We had the on-target trial in which patients at high risk for vascular events, either telmisartan or ramipril can be used. So it did not. What it showed was that telmisartan was not inferior to ramipril, but it was better tolerated because, as we know, AC inhibitors they have side effects like cough and angioedema, which was not with telmisartan. So with the same efficacy, we had a drug which was better tolerated.
I think
Also,
there is
telmisartan
something
had a
background
data in
sound is coming on.
It is
From-
MI stroke after 6 months of
From
treatment.
any technical,
Can value.
So,
We
technical
also,
kindly just mute others.
team, please mute technical team.
Yeah, sir, we are live again.
Yes, sir. You can start, sir.
So shall we start now?
Yes, sir. Sure, sir.
Okay, from now onwards to just so thank you, Glenmark team, for giving me this opportunity to talk about this topic regarding optimizing hypertension management with triple combination therapy.
Thank you, sir.
So learning objectives. What are the learning objectives? First, describe the burden of uncontrolled hypertension in the Indian population. Apply current AHA or ACC, that is American Heart Association, and ACC 2025 and ESC, that is European Association of Cardiology 2022 treatment algorithm through clinical scenarios. Identify patients who have failed dual therapy and required escalation. Justify the use of triple fixed dose combination, and that is FDC therapy like ARB plus HCB plus thiazides. Initiate, titrate, and monitor telmisartan, amlodipine, hydrochlorothiazide in practice. Counsel patients on adherence strategy for long-term blood pressure control. So coming to the section 1, which is the global and Indian hypertension crisis, prevalence, control, and cost. So this global hypertension burden, that is hypertension, is a silent global crisis affecting almost more than 1 billion lives. Less than half receive treatment, nearly half remain undiagnosed. Only 1 in 5 achieve adequate BP control. And the major drive of cardiovascular disease, stroke, and premature mortality. The hypertension epidemiology in India, the lead we can't celebrate. There is almost 300 million people, they are living with the hypertension, and almost 12% have annual mortality rate. In the European region and the Americas, the number of adults with hypertension rose from more than 302 million, that is from 1990 to 2019 up to this 427 million, reflecting a 41% increase in the cases of hypertension. Contrast, the Southeast Asia and Western Pacific regions showed a steeper rise from 262 million to 640 million, corresponding to a 144% increase. The disproportion growth in Asia Pacific regions highlights the impact of rapid urbanization, lifestyle transitions, and population aging. So there we can see that there is a huge reflecting the increase in percentage from of almost 41% from 1992 up to 2099. And gradually again from 2019 to 2026, it has also more than the data what we are seeing has also been increased. So premature hypertension in India, the early onset of major cardiovascular risk factors, including hypertension and dyslipidemia, driving premature disease as shown in Interheart study. Identification of 12 key cardiovascular risk.
Hello. Slides are not changing. I would request you to please exit the full screen mode. The slides are not changing.
Yeah, slides are not changing. Hello. The slide is watchable to or not to you all. Identification of 12 key
Sir, the slides are not changing, sir. Would request you to exit the full screen mode, sir.
Yes, doctor.
Again, is this visible to you all?
Yes.
The slides are visible, sir. Yeah, it is changing now, sir. Hello.
Yeah.
Yeah, it is changing.
Identification of 12 key cardiovascular risk predictors in large Indian cohort. That is, the sample size is from 33,583 and the 85% Indian population in pure study. High population attributable contribution of hypertension, raised non-HDL, cholesterol, diabetes, abdominal obesity, low education, indoor air population, and tobacco use. Pathophysiology overview. The RAS, that is renin-angiotensin activator system overactivation. There is increase in angiotensin 2 enzyme that leads to vasoconstriction. There leads to aldosterone release and thereby sodium retention. Sympathetic overdrive. Again, it increases the heart rate, cardiac output, increases the peripheral vascular resistance. Thereby, the vascular stiffness of endothelial dysfunction is reduced. no bioavailability, arterial rigidity, and the volume excess. It is impaired renal sodium handling, thereby comes to the fluid retention and then raise the preload. So target organ damage is hypertension, which is a vicious cycle like increasing the arterial stiffness, thereby vascular dysfunction and vascular remodeling, which leads to left ventricular hypertrophy, coronary artery disease, cerebrovascular disease, cognitive impairment, chronic kidney disease, also the proteinuria. So this all leads to cardiovascular events. The cardiovascular disease risk assessment. It is a prevent calculator, like incorporates like age, BP, lipid profile, diabetes, kidney function, BMI, smoking. Available tools according ASCVD risk estimator plus and ASCVD, that is the 10-year risk. That is low if it is less than 5%. If 5 to 10% is borderline, intermediate 10 to 20%, high more than 20% as per pool cohort equation, and which is tier 2 less than 130 by 80 if 10-year risk is more than 10%. So evidence based, this is the population group like general adults, where the BP target is almost 130/80 by 80 in case of general adults, diabetes CKD patients. If the age is more than 65 ambulatory, then these are evidence based like in ACC or AHC 2025 class 1 indication, then or the UK PDS study, ECORD study, or sprint subgroup study, or sprint trial. In case of pregnancy, as per the ACOG 2024, it has been recommended that the BP must be or less than 140/90 limiter of mercury. Section 2, that is the AHA or ACC 2025, ESC 2024, and defining the dual period. So the ESS 2024 stepwise approach. The step 1 is lifestyle modification and monotherapy. That is a DASH diet. Sodium reduction, that is less than 2 grams per day. Aerobic exercises, more than 150 per minute per week. That is 30 minutes per day for at least 5 days in a week. Monotherapy, inspected patients like low risk of hypertension, high normal blood pressure, and very high cardiovascular risk, or trial like ACE1 inhibitor or angiotensin receptor blocker or calcium channel blocker, thiazide or thiazide like diabetic. The step 2 is dual FDC, that is fixed drug combination if not at a goal. That is preferred could be the ARB plus CCB combination or ARB plus thiazide. The FDC preferred for adherence advantage. The step 3 is triple therapy, that is the resistant hypertension workup. If more than 3 agents, despite of their optimal doses, then preferred could be the ARB plus CCB plus thiazide. It is considered that the mineralocorticoid antagonist like spironolactone as fourth agent in 2 resistant hypertension patients. Again, this is a select therapy. Select therapy pharmacological treatment. Once daily dosing preferred in the morning, like step 1 again, as we have discussed in previous slide, that they start the dual combination therapy like ACE inhibitor or ARB plus CCB or diuretic. Then go to or increase to the full dose unless it is well tolerated. That is up to 60% is controlled. If not, then we have to switch to the ACE inhibitor or ARB plus CCB then plus diuretic. That is almost we have to go to the 3 agents. That is antihypertensive agent. And if more than 3 antihypertensive agents up to 90%, the patients have control, but some of the resistant hypertensive patients in which we give all these 3 antihypertensive drug, and despite of that the patient doesn't in control, then we switch to the other molecule, or they consider to consult hypertension specialist if patients who are not, still not controlled. So BP can be used as the beta blocker can be used as monotherapy or at any step of combination therapy. The use of diuretics, the consider transition to loop diuretic if EGFR is between 30 to 45 ml per minute or per 1.3 meter square. If EGFR is less than 30 ml, we use loop diuretic. Consider combination with clothianidone or other diuretic. Use of beta blockers should be used as guideline directed medical therapy in respective indications or considered in severe other conditions. Then the BP would be controlled if BP is less than 140/90 is used in the 2 resistant hypertension cases, like if despite of giving 3 antihypertensive and your systolic is not controlled, that is more than 140, or diastolic more than 90. Then provided that the maximum recommended and tolerated doses of 3 drug combination comprising a RAS blocker, that is either ACE or ARB, CCB, and thiazide or thiazide like diuretic are used. Now, various cases of pseudo-resistant hypertension are the cases who are having especially poor medication adherence. And we have to exclude the secondary hypertension. Like consider additional therapies or drug or renal denervation like insulin-resistant hypertension patients use spironolactone or other MRA with caution like eGFR is less than 45 or serum potassium more than 4.5. Now beta blocker or alpha 1 blocker or centrally acting agent and direct vasodilator could not be preferred. Renal denervation in heart failure, ARNI or agent 2 inhibitor, and in CKD patient agent 2 inhibitor and NS-MRA that is phenomenon. It's not a combination with the MRA. The blood pressure lowering strategy in patients with elevated BP and hypertension is the European Society of Cardiology 2024 guidelines. Now, initial monotherapy could be preferred like elevated blood pressure category of 120 by 70 to 129 by 89 millimeter of mercury. So it is moderate to severe frailty, symptomatic or orthostatic hypotension is more than 85 years. Then the low dose double combination therapy like ACE inhibitor or ARB or CCB or diabetic, that is class 1 indication. Then in the follow-up at least every year, if you see the BP is controlled after 1 to 3 months, then you have to assess at 1 month preferable if possible. Otherwise, if patient is normal, then good. Otherwise, low dose triple combination therapy, we have to go to the patient who are not BP is not controlled. Again, ACE inhibitor or ARBs, then CCB is diabetic. Then again in follow-up of at least in every year, we have to see at BP within 1 to 3 months. If it is controlled, it is very good. Otherwise, again, we have to increase or escalate the dose of these three combinations of the molecules to their maximum tolerated doses. At any step of the beta blockers, they are the indications of beta blocker adding like post-MI, angina, systolic heart failure, or to control the heart rate. Then they are the class 1 indication in which we can put it in any step to control the hypertension or resistant hypertension case. Now, what are the rationales for combination therapy? The greater reduction in blood pressure compared to monotherapy that blocks the multiple pathophysiological pathways of hypertension, which achieves faster blood pressure control, that reduced adverse effects via complementary mechanism, provides better target organ protection, and offers additional benefits beyond BP lowering or anti-inflammatory metabolic. Why triple therapy beyond dual therapy is a clinical necessity in case of hypertension? The dual therapy limitation, that is 25 to 33% of patients remain uncontrolled on dual combination. That bridging the gap, that is triple therapy, is the most logical next step to achieve our BP target. What is the rationale for triple combination therapy? Now, large studies like SCOPE, INVEST, all had accomplished trial that show a substantial proportion of 30 to 50% of patients that requires more than 3 agents. Even in case of moderate or uncomplicated hypertension, more than 30% needed the triple therapy. That is a STITCH study. In triple therapy associated with higher BP goals, the achievement is more than or 65% approx. In recommended in patients with high baseline blood pressure, it is more than 20 in systolic or 10 millimeter of mercury in the diastolic or your target in cases of high cardiac exposure. So the review article by GZOL et al. Supports key take-home messages pertaining to new treatment strategy for the management of hypertension. We have start treatment in most patients with 2 agents, not only one. Like in some patients, that is those at high cardiovascular risk, triple combination therapy is favored by the authors. Use single pill combination therapy whenever possible. Use the simplified drug treatment algorithm of ACE inhibitor or ARB plus CCD or thiazide like diuretic for dual therapy, and all 3 agents for triple therapy. And use a beta blocker when there is a specific indication for its use. Now, evidence for early triple therapy. The representative trials comparing triple combination therapy with 2 drug combination, like efficacy in this bracket, this is telmisartan or hydrochlorothiazide plus amlodipine combination. That is in combination of telmisartan 80 mg, amlodipine 10 mg, and hydrochlorothiazide up to 25 mg. So it has been seen that the baseline decrease in the systolic and diastolic reduction was up to approx systolic blood pressure of almost 18.7 millimeter of mercury, and diastolic blood pressure BP reduction was up to 9.3 to 13.9. So either you use hydrochlorothiazide or use this chlorsolidone Then there is also significant, we have seen that the chlorothalidone, while using the same combination of 20, this, in the low dose triple combination therapy, they have also proven that the systolic and diastolic decrease has also been increased up to 10 to 20 millimeter of mercury. Now, section 3 is the telmisartan plus amlodipine plus hydrochlorothiazide. What is the mechanism, efficacy, and positioning? Now, this triple therapy, first we are coming to the ARB, that is telmisartan. It blocks the angiotensin 1 receptor. Now, what does it do? It decreases the vasoconstriction, thereby decreases the aldosterone, decreases the sympathetic activation, thereby decreasing this PPAR gamma agonism factor, decreases the metabolic benefits, and also it has the insulin sensitization effect. Then comes the second one combination, that is the second component, that is the CCB like amlodipine. It acts on L-type calcium channel blocker. It has also arterial vasodilation. It decreases the peripheral vascular resistance. It has long half-life. So there is smooth 24-hour BP coverage, no reflex tachycardia. Then the thiazide, which is hydrochlorothiazide, it has renal sodium and chloride co-transporter inhibition. It decreases the plasma volume, decreases the cardiac output, vasodilation at low dose. At 12.5 milligram, the natriuretic efficacy with minimal metabolic effects. The complementary mechanism of combination antihypertensive therapy like an ARB, CCB, and a thiazide diuretic. Then we have seen that this flow chart. Like the CCB mode of action is it acts on the L-type calcium channel blocker that increases the arterial vasodilatation and thereby decreases the BP. The ARB, it has mode of action like the angiotensin converting enzyme, which blocks and thereby it decreases the vasoconstriction, aldosterone secretion, catecholaminergic release, and it increases the vasodilating effect, thereby also decreases the blood pressure. The diuretic mode of action that we know, that is the natriuresis, the volume depletion, thereby it decreases the total peripheral resistance and thereby decreases the blood pressure. So in the combination of all these three, they have their pathophysiology mechanism, and thereby it all have shown to decrease the blood pressure. The pH component profile, like telmisartan 40 mg, that is the angiotensin receptor blocker. It has half-life of 24 hours. It is the longest ARB we have. Once daily dosing, no active metabolite needed. It has PPAR gamma partial agonist, thereby decreases the insulin resistance, decreases the triglyceride, and increases the HDL component, which is a very important part of this molecule. It has also renoprotective action, like it decreases the albuminuria, which we know, and it is independent of blood pressure. On target trial, there is a non-inferior to ranitidine in cardiovascular outcomes. Coming to the amlodipine, which has 5 mg, it has also the dihydropyridine calcium channel blocker of group. Then its half-life is of 35 to 50 hours, which is ultra long. So gradual onset, no reflex tachycardia, the coronary vasodilatation, anti-angival benefit. Now all heart and trials compared to the CCB arm, there is also been shown that it decreases the stroke versus PAC inhibitor. The dose rated ankle edema 5 mg minimizes this rate. So coming to the, if we took the amlodipine 5 mg, then there might be option of that the ankle edema, which is a very common side effect of this group of molecules, particularly with amlodipine. With the dose rated, it has also seen that there is the least side effects of this molecule. Coming to the hydrochlorothiazide, which is 12.5 milligram, that is the thiazide diuretic, and its half-life is almost 6 to 15 hours. So low dose, that is natriuresis, without any significant hypokalemia, metabolically favorable at less than 12.5 mg. It has synergizes with ARB, it counters RAS for retention. And in the OLED trial, is proven cardiovascular outcome benefit at low doses. The adherence or advantage of FDC, 87.5% persistence improvement, more than 78.3% adherence improvement, and more than 23.3% goal in the BP achievement. So advantage of using this fixed dose combination in a single pill in clinical practice, there has been seen that there is the important part is that there is the reduction of number of pills. There is reduction of number of daily intakes. There is easy prescription and saving time. Reduction of cost also, so profit friendly to the patient. Improvement of adherence and persistence on treatment. Problems with fracturing pills and apparent less close flexibility. Disadvantage of using FDC in a single pill in clinical practice. The problem is fracturing pills and apparent less close flexibility. So guidelines positioning of TH. The guideline as per the European Society of Hypertension 2024, the triple therapy position they have kept in at a step 3, that is the post dual failure, and preferred combination is this ARB, CCB, and thiazide guideline. In the ESC 2024, again, it has stage 2 uncontrolled, or in the case of when the dual therapy is uncontrolled, then we can go for.
Sorry to interrupt. The slide is not showing.
From where? From which slide?
It is on 6th slide right now.
6th slide.
Yeah, sir, you exit the full screen mode. Don't make full screen, sir.
Okay, but presently I am on the 22nd slide.
Yeah. Now it is visible. Exit the full screen mode, sir. Don't make it full screen. Okay.
Okay. So shall I start from the current slide only from which I was?
Yes, you can continue.
Okay. So this is the TH from the again GNC 8 and ISX 2520. They have also attributed to the resistant hypertension. There we can go for the 3-drug combination. The Indian guidelines 2025, they have kept in the triple therapy in the second line, and the ARB plus CCB plus diuretic. In cases of INSH, that is uncontrolled dual, after dual therapy, we can go for again the ARB or AC inhibitor plus CCB plus diuretic. So in TH, FDC, the telmisartan 40 mg plus amlodipine 5 mg and hydrochlorothiazide 12.5 mg. This guideline involves first choice for triple therapy post dual failure. And all 3 classes, that ARB, CCB, and thiazide carry class 1 level A recommendation across major guidelines when used in combination. Now, section 4 is the patient journey from dual failure to a PH success. Now, it is a case 1 like 55-year-old male uncontrolled on dual therapy. The patient profile is 55-year-old male having type 2 diabetes, mellitus of HbA1c of 7.2%, BMI 27.4 kg, non-smoker. The current treatment he is taking is telmisartan 40 mg, amlodipine 5 mg for 6 months, both at optimal doses. In the clinic BP, the patient Menendez has got 165 by 102 millimeter of mercury, which is average of 3 readings. The ABP confirmed of 162 by 99 millimeter of mercury, which is a 24-hour mean value. eGFR is 68. The UACR that is 52 milligram per gram, and this potassium is 4.2 milli equivalent per liter. So the 23% high, this is the 10-year ASCB disease. The BP target must be at least 130 by 80, and the current BP is 165 by 5 by 102. And there is a gap of goal of almost 35 to 22 millimeter of mercury. So the systematic evaluation before escalation. Verified drug adherence, the pill count is 27 by 30 pills, almost 27 pills is taken out of 30 pills. So prescription refill on time, adherence confirmed. The ambulatory blood pressure monitoring, that is 24-hour mean, is the 162 by 99, so white coat effect excluded, and 2 uncontrolled blood pressure confirmed. The exclude secondary hypertension, that is renal ultrasound, that is normal, aldosterone ratio normal, PSH normal, so it excludes the secondary causes of hypertension. Again, the confirm the adequate doses, like telmisartan 40 mg, amlodipine 5 mg, both at optimal doses to consider a titration or escalation. Then lifestyle assessment, like dietary sodium, he was taking almost 3.8 gram per day. Our target must be less than 2 grams. Sedentary, that is 60 minutes or less than 60 minutes exercise per in a week, and overweight, the BMI is 27.4. So next step to escalation to triple therapy, all criteria made for the dual therapy failure, and then initiate to the TAS, that is telmisartan amlodipine hydrochlorothiazide. Now, where TH fits guideline-based positioning? Step 1 is lifestyle plus monotherapy. Then step 2 is ARB plus CCB dual FDC, that is telmisartan 40 mg plus amlodipine 5 mg. Again, step 3 is the TH fixed drug combination. That is telmisartan 40 mg, amlodipine 5 mg, and hydrochlorothiazide 12.5 mg. And step 4, if needed, then add spironolactone, that is 25 to 50 mg, that is the resistance hypertension. Suggested optimized management. 1 tablet once daily taken in the morning with or without food. The rationale, that is add hydrochlorothiazide 12.5 milligram to existing this ARB-CCB backbone. Logical guideline involves equal step. Simplification, replace 2 tablets with 1 FDC and improves adherence, reduces the pill burden. The initiation and monitoring protocol. Day 0, that you initiate the TH-FDC. Again, in week 1, you have the home BP monitoring twice daily, more than 6 readings over 3 days before review. In week 4, first review the clinic blood pressure. In home BP, BP monitoring diary. In labs, you can exclude the hypokalemia plus the AKI component. You have to assess the ankle edema, dizziness, adherence to the therapy or not. In after 3 months, you target the assessment like your aim must be the BP that must be at least less than 130 millimeter, 130 by 80. You must repeat the USCR and expect to decrease with the ARB if uncontrolled. Up titrate the amlodipine 10 mg or add portal. And 6 month therapy follow up. You have when the patient is at long term management. And 6 monthly clinical review, your annual PCG, ECO, LVH regression, then dietary reinforcement, and home BP monitoring ongoing must be seen. Take 4 response, that is TH initiated. The systolic blood pressure reduced by 23 millimeter of mercury and diastolic by 14 millimeter of mercury. No adverse effects reported. The serum potassium, that is at 4 milliequivalent per liter, is stable. Creatinine rises to plus 0.5 milligram per billion, that is expected. The patient reports good tolerability, no ankle edema. The home BP monitoring ID considers readings at good adherence. At month 3, achievement target reached, like your goal BP achieved is less than 130 by 80. The ABPM is 24-hour mean is 126 by 77. That is also sustained control. The USCR 52 from 31 milligram, that is 38% reduction. HbA1c 7.1%, that is no glucose deterioration. eGFR is stable at 66 millimeter ml. No hypokalemia, no adverse effects seen at the 3 months. So long-term management plan every 3 months clinical BP measurement plus HBPM, that is the home BP monitoring, diary review, medical adherence assessment, lifestyle counseling reinforcement, that is sodium to take less than 2 grams, exercise at least 30 minutes in a 5 days. The weight reduction increase for about the weight reduction in every 6 months. You have to see about the full metabolic panel like HbA1c, repeat function, your renal profile. You can choose the serum electrolyte also. The USCR is the assessment. The review again the home monitoring. In annually, you have to again go for the 12-minute ECG, assess LVH regression. Then echocardiography, it will take for the left ventricular mass index for diastolic dysfunction. Ophthalmology review, that is flow management with the diabetes. The consider ABPM or if white foods effect suspended, affected. Lifestyle ongoing, that is the dash diet, less than 2 grams sodium per day, fruits, vegetables, whole grains. Aerobic exercise is more than 150 per minute in a week, like walking, swimming. Target weight must be the BMI less than 25 kg per meter square. Waist at least 90 centimeter, less than 90 centimeter for male in Indian. Patient communication and adherence strategy. 1 tablet once a day, all the blood pressure medicines in a single pill. Your kidneys are being protected by this condition. It's doing more than just controlling blood pressure. Take it every morning before leaving for work, link it to daily living habit. And check your BP at home twice in a week. Bring the diary, you are part of the team. So you have to emphasize simply highlight the organ protection, adrenal and cardiac. We have to also behavior anchoring strategy and the home BP monitoring, engagement and empowerment. This is equally important while controlling the blood pressure, and together with the team, we can achieve this. Case outcome, that is from dual, we have shifted to triple therapy, and goal in 12 weeks, we have seen that the 12 weeks in almost 3 months, the target BP was achieved. There was a reduction of almost 27 millimeter of systolic and the 23 millimeter of mercury in the diastolic. And again, there was also a reduction of 40% in the urinary and platelet density. Coming to the case number 2. The case number 2 is 45-year-old man, which is early initiation of triple therapy. The patient profile consists of 45-year-old male, newly diagnosed of stage 2 hypertension, BMI 30 kg, non-smoker, family history of premature cardiovascular death. Father had MI at 52 years of age. The clinical BP was 160/106, average of 3 readings on 2 visits. The ABPM confirmed of 166/104 at 24-hour mean. EGFR is almost 82 ml per minute. The USCI is 38. Potassium is 4.4 and LDL is the 148. And no diabetes, secondary hypertension was also excluded. So the 10-year this CVD risk was 80% higher. The BP target is less than 130/80. We must be, but the present BP is almost 160/106. So the gap of the goal was of 38/26 millimeters of mercury. So rationale for early triple therapy guideline-based decision. First, we have to the as per AHA and ACC 2025 and ESC 2024, BP more than 20/10 millimeters of mercury or target with high cardiovascular disease is considered initiating the triple therapy of term. So how the BP target of BP was more than 20/10 millimeters of mercury was the target, and the second was a high cardiovascular risk profile, as we have seen mentioned, and the third was the target organ damage, which is already present. So decision initiate the TH-FDC like clinical 40 mg plus 145 milligram and the hydrochlorothiazide 12.5 milligram as first line therapy, and guideline involves a step 2 stage 2 hypertension with high cardiovascular risk in this case. For treatment response, if reports which include the blood pressure was of less than 146/90. And at 3 months target, there was received the target was achieved of 126/78. At the systolic blood pressure reduced by 42, diastolic by 28, and the goal was less than 130/80 and achieved. So UACR was also improved, that is came down to 38 to 22. Early reduction telmisartan, consistent with the on-target trial data. The serum potassium was 4.2. The EGFR is 80 ml. No, there was no any ankle edema and excellent tolerability. LDL is 148. Statin added at month 1, and home BP monitoring diary adherence was excellent with single pill at disease ready. The case outcome early TH goal at 12 weeks sustained at 6 months. The clinical lesion from early triple therapy in a 45-year-old person. This patient profile we see that early intensification prevents regression of ACR from 30 to 22 within 3 months reflects early nephroprotective benefit of ERB. Again, the stage 2 hypertension with high risk, we have seen that as per AHA, ACC and ESC guidelines support bypassing the sequential dose, then people escalation of BP more than 20/10 millimeter of mercury. Here the target blood pressure with high cardiovascular disease. So that triple therapy is guideline indoors. Single pill FDC drives adherence in a younger working age patient, and the FDC adherence advantage 87.5 persistence versus free combination is especially critical in active working age adults, and TH simplifies the regimen to one tablet daily therapy. The section 5 is clinical trial subgroup data and safety profile of TH. The TAHY-T1 trial study overview. So the aim was to evaluate the efficacy and tolerability of telmisartan and amlodipine plus hydrochlorothiazide compared with the telmisartan and amlodipine alone in patients with essential hypertension. So a study design was an 8-week study randomized RCT trial, compared study in the 14 patients, 4-week running with the TA that is 45 and at 2-week randomization, and the TH versus TA. That is triple therapy versus the dual therapy in 6-week dose escalation phase. The comparison was TA plus hydrochlorothiazide versus TA alone. The population with essential hypertension, and they were eligible after initial treatment with the TA 45. The safety profile was the primary change in mean sitting systolic blood pressure at week 8. The secondary change in systolic blood pressure at week 2 and diastolic at 2 and 8. The PP control rate, response rate. So these were the findings. So the key takeaway was the TH achieved significantly greater systolic blood pressure reduction versus TA, and TH showed superior diastolic blood pressure reduction versus TA. Additionally, the TH consistently achieved high blood pressure control rate versus the TA across all subgroups. The superior efficacy of TH observed both at early and sustained at week 8. The greater BP control with TH irrespective of comorbidities like diabetes, CKD, or both. The TH demonstrates more effective and consistent BP control attainment compared to TH. The phase 3 clinical trial study overview. The aim is to investigate the efficacy and safety of a combination of TAT or amlodipine 5 hydrochlorothiazide at 12.5 for the treatment of hypertension. So this is the study design of third period phase 3 multi-center study site RCT double-blind active control parallel group study. 6 weeks open label running telmisartan 80 mg per amlodipine 5 mg and 8-week double-blind trial. This was a study population of Japanese adults more than 20 years having hypertension and based on 2-3 antihypertensive drug at baseline. So the primary reduction in mean seated double blood pressure at 8 weeks. The key secondary reduction in mean seated systolic blood pressure at 8 weeks. So and other secondary the BP control was diastolic greater than 90 and systolic greater than 140. So they have also seen that in the triple therapy that it is they have shown there was a decrease. There was a reduction of almost 3.9 millimeter of mercury in diastolic, the 5.3 millimeter of mercury in systolic. Additionally, the BP control and response rate, that is the triple combination therapy, delivers superior BP control. It is consistently delivers superior BP control across all the endpoints versus the dual therapy. It's clinically meaningful improvement evident as early as week 4 or further amplified by week 8. It achieves also the high control and response rate across systolic and diastolic blood pressure and composite target, demonstrates the greater efficacy in both absolute BP reduction and target achievement. It supports the need for early intensification beyond the dual therapy to overcome residual uncontrolled hypertension and consistent, robust, and clinically meaningful benefits across all the treatments. Evidence from India, the literature proven BP control with telmisartan amlodipine hydrochlorothiazide in Indian patients. So triple therapy in essential hypertension. The aim was to assess the efficacy and safety of triple combination versus dual therapy in essential hypertension. They have again the randomized study of 20 patients. The systolic blood pressure was 140 to 200 and diastolic was 30 to 120 millimeter of mercury. Adult male and female patient baseline assessment of BP, LAS, and heart system was done. And the result was the superior reduction with triple therapy by 7.9 millimeter of mercury in sitting position and of 6.9 millimeter of mercury decrease in the supine position. Again, in the diastolic blood pressure, there was superior reduction with the triple therapy by 3.1 millimeter of mercury in the sitting position and 4.1 millimeter of mercury in supine position. Efficacy and safety of triple FDC study overview. The aim is to assess the efficacy and safety of triple FDC, that is telmisartan amlodipine hydrochlorothiazide in uncontrolled hypertension. The study design is prospective open label single arm study, that is 120 days of treatment with once daily triple combination and with the follow up at day 30, 60, and 120. The population, 30 patients with uncontrolled hypertension, the systolic is more than 160 and diastolic more than 100. Uncontrolled on dual therapy, telmisartan amlodipine or telmisartan plus hydrochlorothiazide. Safety profile, primary reduction in systolic blood pressure and diastolic blood pressure over 120 days. Secondary is the safety and tolerability assessment. The TH achieved significant BP reduction at 120 days. The systolic blood pressure 30 millimeter mercury, diastolic 19.4 millimeter mercury, and with 100% of patients achieving the target blood pressure. Take home first implementation and question answer. The management flow summary. First to diagnose the stage second hypertension, that is BP is more than 140 by 90 millimeter of mercury, confirmed with ABPM and home blood pressure monitoring. Assess risk, that is prevent ASCVD calculator, DM or CKD, less than 130 by 80. Then dual FDC, that is ARB plus CSP preferred, review at 4 to 6 weeks, optimize the lifestyle. Then it is the dual failure, then we keep more than goal of the 2 agents, verify adherence and exclude the secondary hypertension. Then the TH triple, that is triple therapy. You have to monitor the potassium creatine at 4th week and target must be at 130 by 80 if the goal is achieved. Then less than 130 by 80 millimeter of mercury, sustain long term annual echo and labs should be done as which has been mentioned in the previous slide. If uncontrolled on TH triple therapy at 4% like spironolactone 25 to 50 mg, investigate resistant hypertension and then considered specialist preference. The five key clinical pearls. Early escalation of triple therapy is essential in patients uncontrolled on dual therapy, especially when BP is more than 20 by 10 millimeter of mercury as the target. ARB plus CCB plus thiazide combination target complementary mechanisms leading to greater and faster BP reduction. Triple fixed dose combination improve adherence and persistence, translating into better long-term BP control. Addition of low dose thiazide enhances efficacy without significant metabolic adverse effects. Effective BP control with therapy with triple therapy contributes to improved target organ protecting, including renal and cardiovascular benefits. Thank you. So over to the technical team.
Yes, sir. Hello.
Yeah, hello.
Thank you so much, sir, for the wonderful session, sir. You can exit, sir. Now, sir.
Thank you.
Thank you, sir.
Thanks to all of you.